To order the Health and Human Services Committee. To the members, we will not be hearing to 12 this afternoon, and the staff is getting you a copy of House Bill 195. There seems to have been some mix-up, and they're having to get you copies. So for that reason, then we will start with our legislative briefing with Blue Cross Blue Shield. They have on here Grady and several other stakeholders. I've asked that the committee hear this because for the first time in 9 years, I have heard more problems from providers, whether it be hospitals, rural hospitals, or physicians, about the problem they were having with contracting with Blue Cross Blue Shield. I guess when you hear one complaint, you think it's personal. When you hear two, you go, okay, well, maybe. But when you're hearing it from physicians, from hospitals across the state, from small hospitals, from large hospitals, you begin to what the problem happens to be. And then with Grady, I will tell you that for anybody that doesn't know, and the newcomers aren't here, Grady holds a special place in my heart. And the reason for that would be that my husband did part of his medical training there. And for each of you around the state that you might not realize how important Grady is, Grady, over 50% of the doctors in this state did a good portion of their training at Grady Hospital. Grady Hospital has our largest numbers of residency slots. And, you know, should anything ever happen to Grady, which almost happened, with it closing, we would lose all of those slots. They don't go to anybody else. And even if Grady were to reopen its doors, we would not get those slots back. So we are already about 37th in there, or 38th in the United States for the number of doctors that we have per 100,000 citizens of Georgia. If you take out the metro area, we drop to about 48, and it's predicted that by 2020, we will be 50th in the United States of the number of physicians that we have to treat Georgia patients. And I am very concerned about that, and it will be a huge problem to all of you that come from any rural area in this state. So that's why I have asked people to come and talk to me about it. And since the Grady people are the ones who, you know, really brought this to my attention, and then I started digging into it, I'm going to let Grady make a presentation first. So would everybody that would like to talk on the Grady issue come up and have a seat at the table, introduce yourself, tell us what your role is, there's an extra chair up here, and explain to us in as simple terms as you can, not using initials, because most of us are not, I'm a nurse, but the rest of the committee are not medical, so we need for you to explain it in simple terms.
Okay, thank you, Madam Chair, members of the committee. We do appreciate the opportunity to come before you today. My name is Mark Meyer. I've been the Chief Financial Officer at Grady for coming up on 3 years now. I've got Rick Ryan, who is our Senior VP over Revenue Cycle, and he's been with Grady for 1.5 years now and has frankly taken on the point role with our negotiations with Blue Cross. I will keep my comments relatively brief. I think you all have been handed out a copy of the comments that I was...
Are they in the folder?
Is that... Can you hear me?
Yes.
Okay. So I did have some comments. I'm not going to read this document to you, but I did want to point out a few items in this document that we provided to you just to call it to your attention, because I think they're pretty critical elements. Most of these things you've probably already seen in many of our communications to the media. Just as an overview, as we mentioned, Grady has been negotiating with Blue Cross for over 1 year now, trying to get them to pay us what we believe to be a fair market value rate for Grady services. All of you know that Grady is a level 1 trauma hospital. We provide the most intense level of care, trauma patients, burn patients, folks that have really no other alternative and that's the folks that Blue Cross bring to us because there is no other place to take those patients. The main thing that we've been working on in our conversations with Grady has been the methodology that they use to pay us. As a level 1 trauma center, we have our patients that are with us are oftentimes with us for many days, many months, and there's a chart in this handout that kind of highlights how sick, how ill our inpatients are that come to us from Blue Cross. I did want to say, as a level 1 trauma center, Grady does incur a lot of costs, coverage costs, physician costs, equipment costs. There's just a lot of millions and millions of dollars worth of costs that Grady has incurred over the years in order to provide level 1 trauma services. When we talk about Grady being unique, it's because there are no other level 1 trauma centers like Grady in the state of Georgia, and frankly in the southeast region there's very few that provide the level of service, the level of care that Grady provides. On this, and again, I'm on the second page of this handout. I know you've heard us say that Blue Cross, their reimbursements are less than what they pay other community hospitals. We've been out of network now for about 2.5 months with Blue Cross. We have been getting a lot of claim information from Blue Cross, so they are processing our out-of-network claims. Those claims, they are paying us 35 to 40% more out-of-network than they were before when we had a contract with Blue Cross. That is what the Grady has maintained from the start, that we are not being paid fairly. We're not being paid for the level of care that we provide. When you're out of network, it's called usual and customary. Managed care companies are obligated under law to pay out-of-network providers usual and customary, which is basically an average of what they pay everybody else. So when they're paying Grady more when you're out of network, clearly we are not being paid the same that they're paying other hospitals in the state of Georgia. And that is what we have maintained all along, and Blue Cross's own claim data is now verifying that to be true. There's a small chart there on the second page, and I guess the folks in the back don't have this. We've also maintained that our outpatient surgery, our emergency room services, and other outpatient services are paid less. Grady is being paid substantially less than other providers in the Georgia market. There was an independent survey performed in 2012. We've referred to this in some of our marketing literature and some of our other discussions, in which Grady, as you can see by this chart, we're paid up to 76% below what Blue Cross is paying other providers. Now, for emergency room services, they're only paying us 20% below. So, granted, the range is between about 20 to 75% below what they are paying other providers for that same level of care. That came from an independent survey. About 14 hospitals participated in that had Blue Cross contracts, and that data goes back to 2012. To put it another way, and most folks can relate to this, what Blue Cross pays us for emergency room and outpatient services is less than what Medicaid and Medicare pay Grady. Typically, hospitals at best, you try to break even on Medicare and Medicaid. Everybody knows they're just trying to reimburse you cost. We're being paid less from Blue Cross than we are from Medicare and Medicaid. And so we are losing a substantial amount of money on that outpatient business. Going on to the third page, and again, hopefully I'm moving quickly enough for y'all. The way I look at our payment reimbursement, we call it yield. And quite simply, our yield is if we send a $100 charge to an insurance company and they pay us $20, that represents a 20% yield. So that's quite simply what yield means. You see on this next chart that our yield relative to other hospitals that participated in this survey, 14 other hospitals all across the state of Georgia, we were paid a yield of 23 to 86% below those other hospitals. Again, less than what Medicare and Medicaid pays Grady. if you took our yield, if you took that payment rate up to what they paid on average the other hospitals, that would be worth over $10 million to Grady. That's just on the outpatient business. On the inpatient basis, I've got a chart here that shows 4 metrics, and I'll put this in layman's terms. We measure the level of acuity of patients are measured at a hospital typically in 3 ways. Number 1 is case mix index. That is a financial measure of acuity, financial measure of how sick a patient is when they come to Grady. Typically there's multiple complications. They might have traumatic brain injury, they've been in a significant car accident, have multiple cuts, bruises, could have other complications like COPD, CHF, other issues. Our case mix index was 57% higher than the other 14 hospitals that participated in this study, which should be no surprise. We're a level 1 trauma hospital. Blue Cross sends to us the patients that are sickest that have no other choice. Second, our charges per case, the amount that we bill, was 70% more than those same other 14 hospitals that participated in the survey. So again, the level of severity, the level of care that we're providing to those patients was 70% higher than the other participants in the survey. And then last, and probably most importantly, our average length of stay. The average number of days that a patient spends at Grady was 80% more than the average length of stay they stayed at other hospitals. And so once again, that's a pretty standard metric. When patients are at your hospital 80% longer on average than other hospitals, that means we are doing a lot to take care of those patients. And it's not uncommon for us to have patients from Blue Cross and from anybody that are at Grady for 75, 100, 125 days. Many times it just takes that amount of time to save them, to bring them back. Multiple surgeries involved, skin grafts, other clinical interventions that quite simply just take a lot of time. The last metric is probably the most important. Our reimbursement from Blue Cross for these inpatients in this independent objective survey that included 14 other hospitals was 11% lower per day than the other hospitals. So everything else is a higher level of care, higher level of sickness, higher level of severity. Our reimbursement was 11% lower than they paid on average the other hospitals in the survey. In order to pay Grady comparably to what they paid the other hospitals in the survey, that would be worth close to $13 million in additional reimbursement. So that kind of gets you to, you might have heard we initially asked Blue Cross for about a $25 million increase. It was frankly those 2 metrics that led us to, in order for us to be paid fairly, to be paid what they are paying other hospitals, community hospitals, non-trauma hospitals, non-burn center hospitals, that's the amount that we were looking for to get reimbursed appropriately. On the last page, and I will go through this quickly, we just wanted to show the impact that this out-of-network status is having on the Georgia community. And I'll just say it is critical for Grady to have a contract with Blue Cross. We want a contract with Blue Cross. It is the best thing for the community, for the Atlanta community. Patients that need Grady services need it desperately. And what this chart shows here is that the state health benefit plan employees that are now out of network might have deductibles and copays as much as $24,000 when they're receiving out-of-network services at Grady. So Grady is not helped being out of network. Patients are not being helped being out of network, and employers are not being helped when Grady is out of network. Blue Cross did receive the premiums to be paid, in-network premiums from all these employers, assuming that Grady would be part of that network, and we are not. We are out of network, and frankly, there's only one organization that is benefiting from that out-of-network status, and it's not the employers, it's not the employees, and it's not Grady. I've got a number of notes here about our negotiations, and and folks have said in the media that we haven't been responsive. We have been in constant communication with Blue Cross. We really focused on two major reimbursement metrics. And number one is, as a level 1 trauma hospital, you typically want to be paid what we call first dollar stop loss. So when patients are very sick and they're here at Grady for a long time, they might incur $150,000 in charges. Well, the first $100,000 in those charges will be paid just like any other community hospital. So we lose a lot of money on patients, trauma patients that come in and incur maybe $100,000 or $150,000 in charges, because we might be paid $5,000 or $10,000 or $15,000 for that first $100,000 in charges. So it's a very standard metric. Many other hospitals have first dollar stop loss. I know from personal experience. We know it from surveying other hospitals in the state of Georgia. It is not an uncommon practice to provide first dollar stop loss, and that is what a level 1 trauma hospital needs to have. And then the second piece would be what we call a percentage charges in the ED. Again, in our emergency department, we provide a very high level of care in the ED. It's the busiest emergency department in the state of Georgia, and we currently have various caps on our outpatient services that cause us to be paid less than Medicare and Medicaid for outpatient services. So we lose a lot of money providing that level of care to Blue Cross patients in particular. And so I will pause there and see if there's questions or.
Mr. Ryan, do you have anything to add to that briefly?
No, Mark did a great analysis of the negotiations. Just to reiterate, the conversation with Blue Cross has been around methodology. So if they were to pay us similar to the way they're paying other hospitals in the state, the dollars would just come as a result of that. And they have a challenge in doing that.
Okay. And what you're talking about, you don't have a stop loss. If you had a stop loss, you'd be paid at a higher rate than that $15,000 or so for.
Yes. So our stop loss it starts at $100,000, but we have many patients. So when we say first dollar, it should start at $0. So the first dollar charge starts to get paid at that stop loss rate. And most of our Blue Cross patients hit that stop loss, by far the vast majority, because 75% of our Blue Cross patients hit that stop loss because they are very sick.
And Grady only gets paid once at over $100,000.
We only get paid the stop loss rate over $100,000. We get paid like a community hospital for the first $100,000.
Okay. Representative Kidd.
Thank you, Madam Chair. Two friendly questions, I think. You are basically known as DeKalb Fulton County Hospital, right?
We are known as Grady Memorial Hospital Corporation. That change occurred in 2007.
But you're subsidized by the taxpayers by Fulton and DeKalb County.
Yes, sir. The taxpayers of Fulton and DeKalb reimburse us for some of our indigent care costs.
Right. So you're basically a two-county hospital, but how many counties of patients actually come to Grady? We've got 159 counties, you represent two. So how many of your patients come from other counties?
I hate to be quoted on how many patients come from out of county. We probably have 10%, 15% of our patients are from out of county.
Well,
but when someone's in a car accident or been burned and they're in some county outside of Fulton DeKalb, they're going to come to us.
This is my point, is that other counties have residents who are treated at Grady, that those counties do not help subsidize Grady. And if those patients went to the county hospital from where they reside, Blue Cross would be reimbursing that hospital more than it reimburses you to treat the patient from another county. If there's anything left over, the taxpayers of Fulton and DeKalb have to pick up the bill. Therefore, Blue Cross Blue Shield ought to be reimbursing you the same rate that he would somebody else.
Absolutely.
Okay.
Thank you, Madam Chair.
Thank you. Representative Kaiser.
Thank you, Madam Chairwoman. I'm sure I'm asking a question I know the answer to, but so as a resident of Fulton County and as a member of the State Health Benefit Plan who chose Blue Cross Blue Shield, who wouldn't have chose it had I known the situation earlier, so essentially I couldn't come to Grady for coverage. Is that right?
Well, you can come to Grady, but you will be considered out of network.
Right.
And so there will be, depending on what your out of network benefits are, you would potentially have a much higher out-of-pocket copay or deductible.
So the same for either of my children who are dependents. If they would have to. One's a cyclist. I'm looking for a bumper sticker that says "Take me to Grady." But if
Thank you for that.
But if he, in all seriousness, if he were, unless he were in a serious accident that required emergency treatment, we would have that higher cost if I just wanted to bring him in to make sure there were no internal injuries or anything like that, right?
That's correct. So there are very few services. If you were an HMO patient through the exchange and came in as a trauma patient, we would receive 100% of 100% reimbursement. Those are very few and far between for us. Most of the patients are insured through their employers,
Right.
and all of those individuals who come to us will have an out-of-network penalty assessed on their claim.
So all of the state employee benefit, all of the state employees that are on Blue Cross Blue Shield would pay a higher price.
That is correct. So they will each have the out-of-pocket expenses that are noted in this graph.
Okay.
Anywhere from $12,000 to $24,000.
Okay. Representative Henson.
Thank you very much for your presentation. I'm from DeKalb County, so needless to say, I'm very, very supportive of Grady. I want to go back to something you said before. What is your official name, title?
Mark Meyer, I'm the chief.
No, your title, Grady's title. I'm so sorry. What did you say it was? Grady Hospital something Corporation?
Grady Memorial Hospital Corporation.
Aren't you an authority of the state?
So
Didn't we create you as an authority?
We lease the facilities from the Fulton DeKalb Hospital Authority.
So it's sort of like Hershent Corporation up at
Can we,
Stone Mountain Park?
Representative Henson, can we get to the point, because we're going
My
to be
point
forever.
is, what you're doing is you're serving as a management company to, how does it work? I guess that's really my question.
What is the question in relationship to how they get paid, or what the process?
Actually, it wasn't. I was wondering how they went from an authority to a corporation.
Well,
I think he's explained it, so that's all. Thank
Okay,
you.
thank you. Okay, any other questions from the committee? Okay, no further questions. Thank you very much.
We appreciate the opportunity.
Okay, thank you very much. Okay, Deb Bailey, if you'll come forward up at the mic and or at the table, wherever you're most comfortable. Identify yourself.
Good afternoon. Is this on?
You got it on?
It's
on.
now? Okay. Good afternoon, Madam Chair, members of the committee. My name is Deb Bailey, and I represent the Northeast Georgia Health System in Gainesville, Georgia. I was asked by Madam Chair to speak about our contract negotiations with Blue Cross Blue Shield. First, before I talk about the actual contract negotiations, I'd like to tell you a little bit about who Northeast Georgia Health System really is. We are a 557-bed community not-for-profit hospital that's located in Gainesville, Georgia, and we're opening a second hospital in about 2 months in Brazelton, Georgia. When Madam Chair lived in Gainesville, I think we were about a 150 to 200-bed hospital. Since that time, we have grown. We cover actually over 5,000 miles of territory in North Georgia and serving almost 1 million people. We have 6 urgent cares. We're the second busiest emergency room in the state of Georgia with a level 2 trauma center with about 114,000 visits a year. We have a standalone psychiatric hospital. We have 261-bed nursing home, and we have over 200 physicians or physician extenders that are located in 67 offices in 46 locations. So why is that important? That's important because when you're in a contract, it covers not only the hospital but all of those entities. So Northeast Georgia Health System started negotiations with Blue Cross Blue Shield in January of 2014. The specific details of the contract are usually considered confidential, so I'm going to speak specifically about what this contract negotiation meant to our community and to our patients. So we started the effort in January of 2014. We agreed a number of times with Blue Cross Blue Shield that we would have extensions to this contract to achieve a resolution, but that was not accomplished. There were many times during the contract negotiations where a 3-month period would lapse when we heard back from Blue Cross Blue Shield. So as time and the clock ticked on, August the 13th came, and on August the 13th, Blue Cross sent the Northeast Georgia Health System a letter invoking what is called a run-out period. A run-out period clause in our contract specifically calls for an end of negotiations, and you start preparing for your folks to go out of network. That meant all of our over 200 and something physicians in our community, our imaging center, our heart center, our cancer center, and our hospice would go out of network in 6 weeks' time. The hospital would not go out of network. That was another contract. It was a later time period. So when we received that clause, what we did, we sent out 64,000 letters to our patients at that time. These are patients that were cancer patients, heart patients, hospice patients, pregnant women, patients that were scheduled to have a procedure or scheduled to have a surgery. Again, that's August the 13th. We had from August the 13th until October 1 when these people would go out of network. As you heard before me, out of network means either that physician wasn't covered, that service wasn't covered, or if you did come to that physician, you would pay more out of pocket. We took that 6-week period, we took an entire team of people from what they were doing in the organization, myself included, to start reaching out to the providers, because it was also time for the folks that were in Blue Cross to determine whether or not, particularly the state health benefit plan, to sign up again. So during that time, we made an attempt to speak to each of those patients individually, because we had to. They needed to know whether or not that they were covered. So let me give you an example of a conversation that I had. First example is a pregnant woman that called. This is her second child. She has Blue Cross Blue Shield. She was a teacher. Her first baby was born and ended up in the neonatal intensive care unit. She had a very expensive bill. She was in tears wanting to know, would she be covered? Those are the kind of things and the kind of anxiety that's created in a negotiation period like that. We had people that were calling a patient, maybe an example would be in chronic atrial fibrillation that was scheduled for ablation or a procedure to help with that heart rate arrhythmia on October 3rd. They want to know if that procedure is covered. Same thing for patients that have been that were in hospice for several months. During that period of time, those patients would have to go into a different hospice or pay a different price. Those are the things, without talking specifics about the contract, those are the kind of things when we talk about contract negotiation, those are the anxieties and the fears that are brought to the families that are covered in our communities. And we did, however, before October 1, we were successful in renegotiating a contract with Blue Cross Blue Shield, and that is in place today. It was just the anxiety that's created during that period of time in addition to the anxiety you already have as a patient in any of those areas. So I'll be happy to answer any questions if you have any.
Do you have any idea what all those letters and staff time cost you? An estimate?
No, I really don't.
Well, I've sent out a lot of letters,
yeah.
so I can tell you it's probably getting up at least $100,000 or more dollars. So.
Yeah, I think our real passion was for the patients.
Right.
And the impact to them and everything that we could do to care for our patients and to care for them at home.
Any specific questions from the committee? Okay, thank you very much. Matt, is it Gorman? Gorman?
Thank you, Madam Chair and members of the committee. I'll be brief in respect for each of your time. The preceding presentations have been very illustrative of our situation as well. My name is Matt Gorman. I'm the administrator of Polk Medical Center located in Cedartown, Georgia. Polk Medical Center is a critical access hospital, which means that we serve a rural community and provide essential health care services to the patients in Polk County and the surrounding areas. 3 years ago, Polk Medical Center affiliated with Floyd Medical Center. At that time, Blue Cross Blue Shield was the only commercial insurance company who refused to extend a contract from Floyd to Polk Medical Center. As a result, Polk Medical Center has been out of network with Blue Cross Blue Shield for this entire period. Over this time, we have offered Blue Cross Blue Shield a number of proposals, each representing significant discounts, but they have been refused. Unfortunately, it's the patients, their families, and their employers that suffer from being forced to leave the community for care that could be provided locally, or be forced with paying higher out-of-network fees, as discussed earlier. While we're currently in negotiations with Blue Cross, and we hope that those are productive, the reality is that our patients are the ones who are paying the price. Thank you.
I have a question for you. You're at the Cedartown Hospital, and you went in with which hospital?
Floyd Healthcare.
How far apart are you?
We're about 30 to 35 minutes.
And are you saying that if a patient wants to have a procedure like our teachers that have Blue Cross Blue Shield, even though they lived in Cedartown, if they drove to Floyd, they would be covered?
Yes, ma'am, that's exactly right.
Even though the two hospitals now are joined together and under the same administration? And
yes, ma'am.
okay. I know none of us like to call people bullies. We've had a lot of bills down here with bullies. But that was something that people in private would say. I sort of get the feeling, and did you have the sort of feeling that Blue Cross was like a big bully and felt like they had the upper hand and could do whatever they wanted to do?
I think that's probably a reasonable interpretation. Thank you.
Thank you. Any questions from the committee? Okay, thank you very much. Donald Palasamo? Oh, I have a question. Excuse me just a minute. Who's it from? Oh, wait, he'll wait. He'll wait. Okay. Mr. Palasamo.
Thank you, Madam Chair. My name is Donald Palmazzano. I'm the Executive Director for the Medical Association of Georgia. We represent over 7,500 physicians throughout the state, every specialty, every employment option. We have a very diverse membership. We were asked today to talk about some of the challenges that just physicians around the state have had with Blue Cross Blue Shield. And there's been no shortage of challenges. About a year ago, we had minimal contact with Blue Cross. They had just taken over the state health benefit plan. We'd started to hear from our membership there were a lot of challenges happening. There was recoupment issues on some of the co-pays that were going on. There was a lot of communication problems going on with Blue Cross. And so we had reached out to Blue Cross. And I can say this, is that when we deal with the chief medical officer over there, we're able to get to the people we need to get to. It's when we're dealing with the contracting side and getting the physicians in touch with the people who handle the contract. And that's where the real issue has been. And so what we found is that we took all of the problems that we were having, sent Blue Cross a letter, it was about 5 pages long, outlining all the challenges that the physicians had sent to us and their practice administrators. Blue Cross, to their credit, decided that we were going to have a sit down. We went over to their offices. we outlined our concerns. We had agreed on a couple of things. One is that there had to be better communication, is that the physicians are calling, they're not getting responses, and so the Blue Cross agreed that there'd be a 48-hour response time to any of the physicians that called. The other thing that they were going to do is anytime there was a big, substantial change in any of the contracts or in any of the products, how they deal with things, they were going to get up with us and let us know, because we're the ones getting the phone calls, and we're the ones that have to explain to the doctors what's going on. And so that was going forward what we were going to work on. Unfortunately, that did not happen. Also, we were going to establish a physician advisory committee, and that committee was going to meet on a quarterly basis, and we were going to sit down with Blue Cross and go through some of the, any of the new programs, some of the new things that they were proposing, so they'd get some feedback from some doctors that are in the community. Unfortunately, that did not happen. And so what ended up going forward is that we had not, Blue Cross came out with an amendment that went out across the state around May or July, June or July. And in that in that new amendment, it was actually longer than the contracts that the physicians had. And when we called Blue Cross about it, we said, well, we were supposed to be kind of notified about an issue like this. It's going out to physicians, about 6,000 physicians. What's going on here? And they said, well, no worries, it's just a consolidation of previous contracts. Well, we started to hear from the physicians, and they said, one, it's not a consolidation of previous contracts. There's new products being discussed. The other thing is the sample schedule they gave us does not match the fee schedule that's on the website. So there's a lot of confusion on what we're actually going to be paid on these issues. And so we contacted Blue Cross a number of times, asked them what was the status of this physician advisory committee. We didn't get much of a response. So what ended up happening is that we brought it to the Commissioner of Insurance office. Now, down the line, the Commissioner of Insurance decided to require Blue Cross to rescind the contracts around the state, those amendments. So now they've had to submit the amendment to the contracting process with the Commissioner of Insurance. So with that, to Blue Cross's credit, we are having a meeting this week where we are going to discuss our physician advisory committee. It is meeting for the first time. But prior to that, we were having a number of challenges. And so very high level, the physicians have experienced a lot of frustration. We've heard about it. And we brought it to Blue Cross's attention. And so we'll see what happens going forward, but that's kind of where we are at this point.
Mr. Ponsam, if you can explain, see, one of the things I think I was hearing from Blue Cross Blue Shield about the Blue Cross Blue Shield is that if they had the state health benefit planned employees, they would have to take all other Blue Cross holders at the same price, or that's okay.
Yeah, I don't know that because we don't get into the actual financial discussions with it.
Did they agree to have this meeting after I called this meeting, or was it before?
No, to their credit, this meeting had been in the works, and it was set about 6 weeks ago.
Oh, good. Well, I'm glad they're finally getting around to it.
Yes, ma'am. We'll see how this goes going forward. But we have had our challenges with them.
Okay. Questions for Mr. Palasama? Nope. Thank you very much.
All right. Well, thank you. Thank you for your time.
All right. I only have one person signed up representing Blue Cross Blue Shield, and it's not the people that came and talked to me. Rusty, and I can't remember who else is. Okay. Graham Thompson, are you the only person that Blue Cross and Blue Shield has sent to talk?
They are a member of our association, yes, ma'am.
Well, are they not here, and are they not going to testify?
I believe they do not have plans to testify today, but I believe they have plans to follow up with you.
Okay, they, if they can't honor my request to come and present their case before this committee, would you relay them to them the message that I do not have the time or the inclination to meet with them privately, and that they have disrespected this committee? We are a group of legislators from across this state that are getting complaints about Blue Cross Blue Shield being a bully, and we have a right to ask questions and have them present their case before this committee. I did not mean for it to be a one-sided issue. So if you will relay that to them, and I will now tell the committee, which I was going tonight, I invited the CEO of Georgia Blue Cross Blue Shield. He was out of town at the time I called, but before I told the secretary what I wanted, I asked her to check her schedule for this time today. And she checked his calendar and came back to me and said, he's in town and he doesn't have anything scheduled for that time. But as you can see, he's not here, and neither are his lobbyists. You can come, and make a short presentation to us. But I do not consider you making the presentation for Blue Cross Blue Shield.
There are not enough of these, but I will make sure and get there and collect time for the committee members.
And this is in general about your committee meeting, so I really would hope, as an essence of time, that you hold your comments to while it refers to the issue at hand.
Absolutely, Madam Chair. Thank you, Graham Thompson, on behalf of the Georgia Association of Health Plans. We consist of 6 member plans. Blue Cross Blue Shield is one of our members, in addition to Aetna, Cigna, Humana, United Healthcare, and Kaiser Permanente. Thank you, Madam Chair, and the committee. Just to be clear up front, Madam Chair, obviously, as others have testified here today, these are private negotiations between 2 separate private entities. But I can speak briefly about contracting in general, about what's going on across our very diverse state, while there needs to be different products allowed, while networking and the different types of ways that we develop these partnerships with both doctor groups, hospitals, and other healthcare providers needs to stay as flexible as possible. I know there are lots of proposals out there for the 2015 session for this committee and other committees' consideration, but if I could just quickly, Madam Chair, our members are absolutely committed to providing statewide service, to providing access and affordable care to all Georgians. 3 of our member plans are options on the state health benefit plan. All 6 of our member plans are offering policies for sale on the exchange. If you or your constituents are shopping on the exchange, you'll see all 6 of our members are totally committed to that. And in addition, 3 of our members are offering policies statewide. So there's 16 different geographic rating regions across the state. 3 of our members are totally committed to partnering with your constituents, no matter where you live in Georgia, what county or what geographic rating region. Some of the trends that we are seeing out there, Madam Chair, just today, looking in the news, is provider consolidation. It's not just a single doctor anymore or a single hospital. These are very complex systems that are starting to be proposed. Some of those consolidations have already gone through. Today, Wellstar and Emory are starting to signal that they may partner. We're talking about 1,400 physicians. We're talking about possibly up to 10 facilities. These are very complex health systems, and just as health insurers that have market share, so too these very large health systems that have market share can bully people around too, and these are private negotiations. These contracts can be certainly contentious at times, as we've heard some of the examples here today. But the ability to network with who you need to there's already appropriate oversight in regulatory channels, and the ultimate oversight is out in the employer community. What if the employer doesn't like the fact that Blue Cross Blue Shield doesn't have Gradient Network? One of you that receive coverage through the state health benefit plan may not select Blue Cross Blue Shield next year. All the employer groups, not just small businesses and the self-employed, but national accounts. If you've got folks in Atlanta, but you're headquartered somewhere else, you may say, that's important to me, you don't cover Grady, we're not going to do business with you anymore. So it's very much a tug and a pull between these 2 entities, but they are private entities, and these are private contracts.
Are we not, as a state, paying them a great deal of money, millions of dollars, by them having, as last year, an exclusive for our whole state?
Again, Blue Cross Blue Shield, their personal business relationships, whether with any purchaser, whether it's a state or employer, is confidential. But yes, ma'am, as I understand it, for a limited time before that procurement was amended, they were the sole vendor for the state health benefit plan, and as I understand the way they're compensated, it's based on selection, so they're paid a per member per month fee.
Okay. All right, you're going to need to hit the high points of how it applies very quickly.
Yes, ma'am, and I just wanted to hit on the provider consolidation piece, and then also we expect other bills to come before your consideration, this committee and other committees. We please review the presentation. We'd be glad to catch up with you privately in your offices or, again, attend another hearing. But thank you, Madam Chair. I really appreciate the time.
There's questions for you. Representative Kelly.
Mr. Thompson, thank you for coming before us today. We heard from my administrator at my local hospital, and obviously it's something me and you've talked about before.
Absolutely.
The issue we're having in Polk County, and I always do appreciate you taking my calls when I call to complain about this. But we heard him say for 3 years now in April is how long they've been out of network with Blue Cross. I wasn't in office during 2012, but starting in 2013, and I didn't say anything to you during 2013.
Yes, sir.
But on January 1st, 2014, Blue Cross Blue Shield became the health insurer for thousands of teachers and state employees in my district. So that's where I think we have a limited scope to interfere with two individuals' right to contract.
Absolutely.
And so I'm asking you, so it's been a year now since thousands of teachers in my district have not been able to go to their local hospital, been forced to drive miles down the road. How long should they have to continue to suffer? And what can we do to bring these parties together? I know in the legal field we often try to bring parties together through arbitration. Is that something that Blue Cross Blue Shield would welcome this committee to take up to help encourage these two parties to come to agreement?
Thank you for your questions, and thank you we'll certainly take back your comments, Representative Kelly. Less to the Blue Cross Blue Shield issue there in your district, I can say when there is provider consolidation, there was an acquisition that was mentioned earlier in one of the presentations. What we do see is one entity takes a higher reimbursement rate and applies it to acquired facilities. So we do see that in some circumstances. I'm not saying that's necessarily the case in your district, but that can create a rub, that can create issues for Blue Cross Blue Shield, but they've got to figure out the adequacy of their networks and make sure that they continue those discussions. As I understand it, Representative Kelly, there should be a set arbitration process. There should be totally independent arbitrators involved in that process, but I'd be glad to take back your comments to Blue Cross Blue Shield, and certainly my door is always open.
Thank you.
Representative Hawkins.
Thank you, Graham.
Thank you, sir.
Now, you and I have dealt on other issues with the insurance in the past, and I'd say I think you do a great job. We had some work to do last year with Blue Cross Blue Shield and the other insurance companies. With Northeast Georgia, I think you know that I was involved in some of the negotiations with them and Blue Cross Blue Shield. This summer we had health care hearings, one at Grady, and began talks with Morgan Kendricks and some of the Blue Cross Blue Shield about the Grady issue. I don't see them as bad guys. I mean, I understand that this is a contract and they're representing their company, and really nice fellows. But I hope you understand, and you are too, but I hope you understand that we represent the people of Georgia.
Absolutely, sir.
And the people of our districts. And when we have so many people involved with just a few insurance companies, it becomes onerous on us to become involved with their health and the availability of health care for them. Arbitration is a possibility, and that's something I was going to speak to, but Representative Kelly's already spoken to that. But, you know, I would suggest you take that back to them.
Absolutely, sir, I will.
Thank you.
Representative Kaiser.
Thank you, Madam Chairwoman. Graham, this is not to pick on you. You're braver than I am standing up there. But
Well, considering the fact that the people that really, you know, represent Blue Cross Blue Shields did not have enough guts or respect to show up for the committee.
But I do want to share two concerns with you.
Yes, ma'am.
Originally, you know, when we met with Grady as members of the Fulton Atlanta delegation, we all made phone calls and sent emails, and I don't think they were very well responded to.
Yes, ma'am.
But secondly, can you talk a little bit about the data breach that occurred with the company that owns Blue Cross and how that was resolved? Because I think it was 80 million people, some of whom were us.
Yeah, yes,
Can you just talk about how that was resolved?
Yes, ma'am. Thank you for the question. I can. Again, I'm not a representative of Blue Cross Blue Shield, but they are a member of ours. I can say that Anthem is working with the FBI diligently. I believe that they've started a 24/7 hotline to they're paying for folks' identity protection. They'll help you with free credit reporting, tracking, and all that kind of stuff. But the FBI is involved. This was a very sophisticated breach. I think more will be coming out on that. But certainly, it's a wake-up call to the entire industry, and I can say everybody will be doubling and redoubling their efforts, and I'll certainly keep you in the loop as reforms and initiatives are available.
And can you get the committee members the number of the hotline?
Yes, ma'am.
Okay, thank you.
Representative Kidd.
South Georgia area, and I believe in talking about when the rubber meets the road. So I'll ask you one quick question.
Yes, sir.
If I go to a hospital in South Georgia and Blue Cross reimburses that hospital, that provider, $1,000 for my broken arm, then that same person's in Atlanta and falls and breaks his arm and he goes to Grady, and Blue Cross Blue Shield reimburses Grady or that provider $500 for the same broken arm. A broken arm's a broken arm. And if it's worth $1,000 in one hospital, why isn't it worth $1,000 in another hospital?
Thank you for the question. I'm not trying to dodge you. Healthcare costs are a very, very local thing. If you look at the exchange map of Georgia, there are 16 allowable geographic rating regions which recognize there are some aspects of South Georgia, particularly Southwest Georgia, that are more expensive than even places in Atlanta. So certainly all that, again, is derived from private negotiations, private contracts. Each contract clearly spells out a reimbursement schedule so that hospital, that doctor can expect what to be paid under the terms of the contract.
But a broken arm's a broken arm.
Thank you, sir.
Thank you. Well, Representative Kidd, I think also more in tune would be that if they paid Grady $500 and our rural hospitals, which are on the brink of closing, got $250 because they didn't have the attorneys or the ability to fight against the contracts that were offered. That would be even a bigger problem and is happening across our state. And I will say that the area, in case you don't know, Graham, I was told by the lobbyist for Blue Cross and Blue Shield that they had paid and made a contract with that area that's the highest cost area in our state. So somehow or other, and they said, well, it's a monopoly. So thank you.
Thank you, ma'am.
Like that. So, Mr. Reese. Ah, there you are. I thought you hadn't come. Thank you very much for coming. I've asked Mr. Reese to explain to us, since I didn't really understand it, so don't deal with it. The Blue Cross lobbyists, and I can say what they told me, is the Blue Cross lobbyists told me that they got paid a per patient rate, and that's what they got. It's an administration fee, and the feds said they can only have so much as a margin of profit. So that any savings that they get from playing hardball with providers, hospitals and doctors, was of benefit to the state. And that they didn't get 1 cent extra for going out and browbeating all of our hospitals and everybody for these very low rates that you hear are lower than Medicaid or Medicare, which are the PIDs. So I asked Mr. Reese if that's really how it is, and he said he would come and tell me.
Thank you, Madam Chair.
Tell us.
What we do, to answer your question, the savings that a Blue Cross tries to achieve with providers does not come back to the plan on a dollar-for-dollar cash basis. Now, if Blue Cross goes out, the way we run the state health benefit plan is a self-insured plan. The state itself designs the rates that the employers pay, that the public school systems pay to us to cover their members. We design the plan, which includes the options such as the HMO, HRA, et cetera, the co-insurance, the deductibles, the co-pays that may go with that. And we present them to contractors after approval by our board and say, this is the plan that we want you to administer. And then those contractors, in 2014, it was only Blue Cross. This year, it's Kaiser, United, and Blue Cross as well. Then they, in turn, go out and negotiate with the individual providers, both hospitals and doctors, to create a network that will then serve our members. If Blue Cross or any of the other providers goes to a facility or a practice and says the charge for a certain procedure may be $100, But we are asking you to sign with us for a discount, and we will pay you $50. That $50 delta does not come back dollar for dollar to the plan, but it does, in fact, lower the cost to the plan in the sense that when we pay the claim that comes in as a result of that, it does reflect the discount to some extent. Also, if you are a member and you say you are in a HRA and you're paying, it's an 80-20 coinsurance, that 20% that the member pays would be less based on the amount of the claim. So there is some, it's a complex equation, but there is some validity to that.
Okay. We know that before you got there, Mr. Reese, that somebody in the department and with the commissioner's approval and decided that we would only offer one carrier for the host state. That was Blue Cross Blue Shield. And I think that employees complained, legislators complained, and we said we wanted competition. So in trying to be well prepared for this meeting, I've learned more about how the RFP went out and a little bit about it. If we are going to have competition, it seems like to me that the state, if you're the one that says what we want and want you to bid on, that you would have to have people bidding on apples to apples, not different products. And it is my understanding when the RFP went out for 2015, Blue Cross Blue Shield could have an HSA gold, silver, and bronze, and they could have an HMO. And the other people could bid on only an HMO and a CDHR, which is a high deductible savings plan. Okay, so people, because of our state, we did not have equal things to bid on. And that doesn't seem right to me. If we're going to have competition, I think people should be bidding on the same product. Otherwise, how can you possibly tell what is going to be best for the state? Then I understand that there is some company that the state contracted with, and they tell you when you're doing this contracting how much to say to our employees. The Blue Cross Blue Shield policy will cost you this much, but one at United will cost you 40% more. Now that is way out of skew because the market changes. I mean, and the difference is out in the regular market, United's a little bit higher than Blue Cross Blue Shield. It's about 6 to 8% higher overall. But for the state, it was going to be 40% higher. So when the RFP went out, and when we got the bids on it, when it was offered to our employees, because United was 40% more, only 6% of our employees took United. So we're back to having almost a monopoly. And when you have monopolies, that allows somebody like Blue Cross to Blue Shield to go bully people into taking their lower rates. Can you tell me how that's fair and how that's offering a fair RFP?
We were seeking to balance competing interests. The State Health Benefit Plan, prior to my second tenure as Commissioner of Community Health, was in dire financial straits. At one point in years past, we had about a $700, $800 million reserve. The recession hit, and rightly so, the General Assembly chose to use some of that money to help balance the budget in those tough years. My predecessor, Commissioner Cook, inherited a plan that was in dire financial straits, and the focus of the procurement for a 2014 vendor for plan options was predominantly focused on the financial health and viability of the plan long term. It's still an important consideration for us. So the Blue Cross at that time presented proposed savings to the plan, which the plan at that time chose to contract with them. We entered into a one-year contract, as that's all the state is obligated to pursue, with options. When I came in and we had the serious problems that we had with the 2014 plan and the procurement, we decided to make some changes and try to inject a little more flexibility and bring back some other vendors into the equation. We did not open it up to 100% because we had reached an agreement in good faith with Blue Cross prior to my arrival. And in order to try to be a good partner with someone who we had contracted with in good faith, we decided, because of the contract terms that had been negotiated, and not to just pull the rug out from under them 4 months after that contract began, that we would offer the HRA business to them in this coming year, 2015, and they would seek to have some of the other vendors offer options that were not a part of the 2014 plan year. Your point is well taken, but that was a decision made to balance the competing interests of the plan.
Well, I mean, I don't understand how, if, you know, and Kaiser was in on it, but I don't care if it's United or Kaiser, and Kaiser has its own thing, so it doesn't really go the same way as other. But I don't care what insurance company it is. It seems like that we need some competition. If the state is trying to take care of employees, Mr. Reese, if a lot of those state employees and teachers live across this state in rural areas, and if Blue Cross, because United in this case, who was in on that, is rated 40% higher, which is way, like I said, way out of skew for way it is in the general market. So I think there's something faulty there. It's going to cost employees 40% more. Of course they're going to go and stay with the Blue Cross out of financial necessity. But if the small hospital in their area closes because one of the biggest paying people they had was Blue Cross Blue Shield to sort of balance out what they do in uncompensated care, then our state employees aren't going to be able to get any care. Or they're going to be greatly inconvenienced having to drive 100 miles or wherever to try to get care. You know, I know the state is trying to save money, but I truly believe in competition as a Republican, and I believe that if we have other competing people out there for 2016 or whenever the next RFP comes up, and that you have the same exact plan design and about this in at least a similar contribution level within a 1 or 2 deviation, a percentage of deviation, that we could have cost savings, but also that we wouldn't be driving our providers out of the state.
Well, I will say that we listened and learned from what we discovered in 2014, and we'll do the same for 2015.
Well, and I'm not trying to put you on the spot because, Mr. Reese, we've worked together for several years, and I've always found you to be a good listener and somebody who tried to do what was right. But somehow or other, we're getting this big monopoly, and they're being bullies. And there needs to be a level playing ground. United, Americare, whoever, whoever wants to come and play. We need some competition here. And the competition has to be, and when the RFP is put out, on the exact same plan design, so they are making a bid on exactly the same thing, and with a similar contribution from what our employees will have to pay. I'm just worried about whether we're going to have any providers, especially in our rural areas, like with the doctors. We're paying them below what it costs them to keep their doors open. You and us, we're begging them to take our Medicaid patients, the ones we have now, and then our biggest employer in the state is basically whittling them down and offering lower than almost than we're paying Medicaid patients. How do you expect a rural physician to keep their doors open? Who's going to take care of them? We already have 39 counties that have no OBGYN. If we get a premature baby with no prenatal care, it costs the state hundreds and hundreds and hundreds of thousands of dollars. They're begging for us to make up some kind of difference for them. There has to be some balance in this. And like I say, I'm not trying to give you a hard time, But I'm pleading with you that we don't go through this more than one more year. You have questions. Representative Reinders.
Thank you, Madam Chairwoman. And help me educate me a little bit. I heard you say something to the effect, and I'd ask you to go over it again, about the one-year contract.
Yes, well, the state cannot constitutionally pledge the credit of the state beyond 1 year.
Okay.
So our contracts are all 1 year with varying options, and the 2014 contract with Blue Cross was 1 year with 4 renewable options at our discretion.
Thank you for that. And I thought that's what you meant, but I just wanted to double check. So when you then came back later and said that you reached an agreement in good faith to continue, well, that means to me that you reached an agreement, someone reached an agreement to continue to allow the contract beyond 1 year, which may be the exact reason why we've got 3 plans over here and 1 plan over here. How do you reach an agreement with someone if you're not supposed to, I guess is...
Well, I'm not sure why you'd say we're not supposed to. We have the ability to renew an option that is in the original contract. So for Blue Cross, we chose to do that. We have the same options with United and Kaiser this year. The terms are different because they're not the sole vendor any longer.
But if you've reached an agreement, does the other vendor really have what's the reasonable expectation if you've already kind of committed or reached an agreement in advance that the next vendor actually has a chance of that next contract?
Well, we had a process where you could bid for the contract, and those people who bid knew what they were bidding on and what business would be available.
Did you reach an agreement before they knew what they were going to bid on?
No, the agreement is for the 2015 calendar year.
I'm just having a problem with this as a contract, and the state's only obligated for a year, but I am allowed to talk with you and reach an agreement in good faith. And do all the other vendors know that you've already reached that agreement in good faith?
No, what I'm referring to is that a contract for 2015. So
do the other vendors know you've reached an agreement in good faith?
Yes, they know who we're agreeing with.
So they know the good faith is already in to go with that vendor?
Absolutely.
Okay.
That it? Okay, who else do we have? Henson? Representative Henson? Representative Henson.
Thank you, Commissioner.
Yes.
First of all, thank you for restoring Kaiser. I've heard from many constituents over the years since we dropped Kaiser for the state health, but the region system always kept it. And I have 2 questions. One is, have you intervened on the behalf of state employees to Blue Cross Blue Shield regarding the rate structure and the difficulties that they have in being out of network with Blue Cross Blue Shield in many of our hospitals? Because it affects not only those on state health, but also affects those who are on Medicaid, because those are our dollars, and they're state dollars for both of those.
I have not personally intervened in the discussions between Blue Cross and Grady, only to encourage them to come to an agreement. Our state health benefit plan members who, as a result of trauma or emergency, present at Grady, even though they do not have a contract currently, their care will be paid for as 100% in-network. If they're then admitted as a result of that emergency or trauma, they will also be covered 100% in-network. But if they go for reasons other than an initial emergency or trauma, then that's where the lack of a contract will show up, and we'll continue to monitor. This is the longest that I can recall a large provider such as this going without a contract with a major insurer. So we're not pleased about that, and I'll continue to monitor the progress.
Thank you. And my last question regards the region system. I know they handle their own insurance. They handle it differently. We don't hear that their system's costing them more than in other states, but yet we hear the state health is costing Georgia more than health for employees is costing other states. And I think it's one of the things we're going to be looking at is, have you looked at the region system and how it's handled differently than ours?
We're familiar with the concerns that are addressed on an annual basis about the difference in the plans. It's a very different population, but the governor has proposed in our 15 amended budget and for fiscal year 16 for us to do a study to present to the General Assembly about the cost of the state health benefit plan and ways that we might do that better and reduce those costs. And so we've begun to work on that as we speak.
Thank you very much.
Thank you.
Commissioner Reese, maybe it's time, as representing the largest employer in the state, that you need to step in with Blue Cross and Blue Shield and see if they respect you enough that you might be able to get them to the negotiating table and see if we can. I've been chairman of this committee for 9 years now, since the Republicans took over, and I have never heard of all of the providers and doctors ever having this many complaints and trying to get contracts. And we are in such a state for physicians that when they go to meetings and talk about things like this and what Blue Cross Blue Shield did to them, it does not make us a very friendly state if a young resident is getting out of residency and trying to decide whether they want to come here to practice or they want to go to a state that's more friendly. It's not the only thing. We had some other problems, like a restrictive CON that's too restrictive. I don't want to do away with it, but we could make it a little bit easier for competition. But it doesn't make us a friendly place to have doctors come to help us make up for this shortage. And I am very concerned. Maybe it won't matter if we don't have any place to treat patients, and it won't matter what they're willing to pay if there's no place for them to go or anyone for them to see to be treated. I just know, and as we've discussed, we're in crisis mode, and I think that Blue Cross and Blue Shield have added to it. Representative Kelly.
Thank you, Madam Chair and Commissioner Reese, for being here. You're much more of a healthcare expert than me, so I'm going to maybe ask a couple questions that people here seem to think are elementary. But critical access hospitals and Trauma One hospitals are extremely special hospitals in our network of providers across the state. Is that correct?
Absolutely.
Would you know, kind of off the top of your head, how many critical access and Trauma One hospitals we have in the state?
I do not. I want to say something about 68 critical access, but that number could be incorrect. And trauma level 1, I'm sure the number is less than 10, but we could find out for you.
So 10 at the maximum. So 78 hospitals out of how many hospitals in the entire state?
158 or 59, something like that.
And I understand when you came up with the RFP that it was designed to save state taxpayer dollars and to keep premiums low for the beneficiaries as well. But really, regardless of how low the premiums are or how wisely their taxpayer dollars are being used with the contract with Blue Cross Blue Shield, the teachers and state employees in my community feel like they're getting a raw deal here because they cannot go to their local hospital. And I think that's a shame that we're allowing that to continue as a state. And so what I want to know is what changes are you considering to the RFP to make sure that this doesn't continue? And have y'all considered specifically to make sure that before Blue Cross or any other insurance company can bid for the state health benefit plan contract, that they have provider networks in place with at least these two special forms of hospitals?
Well, they do include trauma and critical access hospitals all across the state.
But not all of them.
Not all of them.
Because my administrator was just here, and he's a critical access hospital administrator, and my parents are teachers. They can't go to our local hospital. My grandmother's a retired state employee, and they're just representative of thousands of people I got in my district who are suffering. So I want to know what we can do to fix that moving forward.
We have not made a decision on any kind of procurement for 2016. As I said, we learned from 2014, and we will do the same for this year. So it's instructive for me to hear your concerns, and we're going to do this study to look at the cost of the plan relative to other insurance products. And I'm sure these will all be things that we'll consider.
And Mr. Reese, I hope that too, I'm sorry, Representative Kelly, that you will also consider some of the tactics that they are using. Like in South Georgia, saying that they can only use their lab, and the one lab they consider their lab may be 50 miles. And we have a huge healthcare problem in diabetes and obesity and coronary problems and high blood pressure and things that cost the state a whole lot of money, and people who have maybe not as much money as they have here and have trouble with transportation and maybe only one car. And so instead of being able to get blood work done locally, they're being told to go 40 and 50 miles, which means many of them do not get the blood work and that the doctor needs to make sure that patient is doing better and staying on medication. The other thing that the Blue Cross Blue Shield people told me is that they would be glad to have an RFP that includes that we have to have a program that shows improved patient outcomes, not just a list that they tick off like now that says, oh, we followed up and called the patient twice, but one that actually shows improved patient outcomes. They're doing this across the country. I don't see why Georgia can't do it. That would be a major way in reducing our health care costs if, with all this money we're paying, we are getting better health care outcomes. People are faring better. They're not getting as sick. So I would certainly hope that we would consider going to that. Representative Hawkins, let you have the last word.
Yeah, just
and thank you, Mr. Reese, for coming.
Yeah, thank you. You've done a great job for us, and I do appreciate it. Excuse me. Got a couple observations. One, as a provider, I remember when we went to the PPOs and HMOs, I started practicing before they were invented, those systems. I vividly remember the promise that if you were out of network, you'd pay just a little bit more. You could always go to any physician, dentist, or hospital you wanted to. If they're out of network, just a little bit more. I submit to you that a lot of what we've heard today is because that is no longer the case, that out of network makes it impossible for the school teacher or anyone else to make that choice. And I would ask if you could move heaven and earth to look for plans that difference is not so great. And then the other thing I'd like to say to you is, and I still don't understand this, and this is what I'd like for you to explain to me. When you say the third party negotiates down the fee with the provider, do they have a bump in their payment for doing that? Is it saving, obviously it should save the state money because we're paying less, we're self-funded, self-insured rather. What's the bump for the third party? I mean, what is the benefit for them?
There's no direct correlation. We pay them on a per member per month basis, and then they go out and contract with their network. Blue Cross, as I understand it, they don't have a state health benefit plan network per se. They have a global network that includes our members as well. And I won't speak for exactly how they negotiate with providers, but I hear the concerns, and it's something that we will address.
Right. Well, I'm not just saying Blue Cross Blue Shield. I'm not beating up on them. I'm talking about all third parties.
I can.
So it's a per member per month fee that we pay our contracted vendors.
Right. So if they negotiate it down, it just benefits the state, nothing to them, right?
That fee does not change.
Their fees does not change. Right. Okay. Thank you.
Thank you, Mr. Reese, for coming. Representative Hawkins, I can explain that to you. I can tell you, and then you'll have to get somebody from the insurance company to really explain it, because I couldn't figure out how they were working it. Representative Hawkins? Yeah. Okay. The way it works is, no, the state, makes the savings. So it doesn't help them there. But it has to do, if they can only pay Grady or some hospital this much, then there's some way that then they can offer to UPS and Delta their product at less and still make a margin of money that they need to make. So that helps them go and get the Deltas of the world and the UPS people and those big contracts. By cutting Grady and our other hospitals and our doctors, it allows them to negotiate a lower rate with UPS and stuff and cut out the competition. And that's how they benefit. Thank you, Mr. Reese.
Thank you.
Thank you for the people that came and testified that, were willing to come and talk about the programs that we have. I'm going to turn the meeting over to my secretary because I have a bill to present. But before I do that, I would like for the committee and members of the audience to remember Representative Beverly. His father passed away this weekend. And the other thing is that I was told today that Linda Womack, who has been a long-time lobbyist for Emory, is in intensive care unit with meningitis and had to be put on a ventilator over the weekend. So it's definitely not a good prognosis. So as you say your prayers today, if you will remember Representative Beverly, a member of our committee, and Linda Womack, and that, you know, that they get through these terrible times as, you know, with as little trauma as possible. Thank you. Okay.
Yes, thank you, Madam Chair. At this time, ladies and gentlemen, I'm pleased to have Chairwoman Cooper present House Bill 195 with her host of all-star co-sponsors.
Okay. Well, you're funny. And if I may, could I ask that Kimberly Greco come and sit with me at the desk?
I would prefer Kimberly Greco. Let me see that. Greco, come and sit at the front desk because she's the Director of Regulatory Policy. You got that? Yeah. Well, Representative Randall. And you may proceed, Chairwoman Cooper.
Thank you very much, Mr. Chairman and members of the committee. I bring before you House Bill 195. How many of you were at the meeting on biologics and biosimilars and interchangeable biologics? Wow, thank you very much for attending that meeting. For those of you not, biologics are a new classification of drugs that have been on the market for a little while. They are helping to control and sometimes completely put into remission people with very serious illnesses and people who have had long-term problems and have been hard to manage, such as really severe arthritis and lupus and some of the cancers. We learned that there is now a biologic out for melanomas. And as this committee has heard before, melanomas basically have been a death sentence unless you got them in the earliest stages. And there's now a biologic out for those to help with that. What the bill is about is the fact that there's also sort of two new classifications of biologics that are coming. One is a biosimilar, which the word that you need to pay attention to there is similar. It's not like it. Biologics are made with living cells. They are not chemical compounds that can be totally replicated exactly. We call those generic drugs. But you know, even with generic drugs, you'll hear patients say, I do better on the brand necessary. I want to go back to that. And the reason for that, even though the drug may be chemically exactly like the brand drug, it may be the coating that holds the chemical together that's causing the difference. But with biological, they are living cells. And we are all made up of living cells, and each one of us is different. So when you put a biologic in my body, it's going to react perhaps differently than if you put it in Representative Sharper's body. So these are high-powered drugs, and they need to be handled differently, and we need to make our laws so that we can handle those and do what's correct. So we've got the biosimilars coming. They're similar. They can't be, can't be exchanged for a biologic because they're not the same. But coming on the market perhaps by the end of this year is something called an interchangeable biologic. That means that that biosimilar has met a higher standard with the FDA that says basically it meets all the safety standards and way it affects people, that the FDA has said, okay, these can be interchanged. But even with an FDA standard, the key here is nobody knows, and the FDA certainly doesn't know, what's going to happen with that interchangeable biologic when it gets in my body or your body. So what we want to do is just make sure that we have good communications here. That if a pharmacist who is a respected member of the team, when the interchangeable biologics come on, and they may be less costly, which will make them more available to more patients, if they have that available, an interchangeable biologic, that they just let the doctor know that they're switching it, and they let the patient know. It's communication, that's all. So that the doctor can watch if anything happens differently in that way that patient is being taken care of. It's as simple as that. Wouldn't the whole world be better if we all communicated better? And as treatments and medicine gets, as I call it, like in space-age medicine, this communication is going to grow even more and more important as we go forward. So basically, this is what this bill is about. It's about patient notification. You know, it's about the fact that we're going to have these interchangeable biologics. It's the pharmacy keeps a record, and you know, the doctor, if he doesn't want it exchanged, can still write "do not change," and you know that's the way it has been even with generics. But if they become available, that if the pharmacist decides to change to an interchangeable biologic, that they just let the doctor know. It's that simple. It's a lot of words for a very simple, and I will be glad to return any questions that you might have.
Thank you. Any basic questions the Madam Chair will be Representative Kelly.
Thank you, Madam Chair, and obviously I'm supportive of the bill. That's why I joined that all-star cast that Chairman Reinders mentioned here. I had a question in lines 80 and 81, and this is a completely friendly question. Where it references on line 80, setting the mood for this question.
Pay the bill. Someone pay the bill. Let there be light.
Where it says, following the dispensing of a biological product, and I know previously in the bill we've talked about a biological product, an interchangeable biological product, and a biological product that is brand specific or brand necessary. Right there, do we want any time that a pharmacist is prescribing or filling one of these orders for them to communicate with the doctor, or only if they vary to the interchangeable or? Okay. Because that's what I was thinking is, should maybe on line 81, just before biological product, we put an interchangeable biological product.
No, and Representative Kelly, I had to have that explained to me, and I had Betsy in my office just before we came on because of this. If you will go down to lines 89 through 92, that will show you that we're talking about interchangeable biologics and that they won't have to notify the physician if it's a refill. But what they're saying is, it may be that one of the PDMs, let's say in the future, has a large amount of this interchangeable biologic. Okay. And they just want, if they're going to keep them on the brand or use interchangeable, just to let the doctor know, one way or the other, so that the doctor knows in the medical record, you know, which one this is. And you want to really know the reason for it being that way was because some people think that if you only have to call when you change it, that somehow that will influence which one and keep pharmacists from using the interchangeable over the brand, that they might be biased. So for that reason, you call if there's an interchangeable biologic available, but you're going to keep them on the brand. You let the doctor know you're going to keep them on the brand. If you're going to change them to the interchangeable, let the doctor know that. You do it one time when you first put them. You don't have to do it for refills.
Thank you so much.
Any other questions for the chair lady? Madam Chair lady, we're going to let you and your guests sit there. We have a host of people in case they have something that you might need to answer. Okay. I think that's the appropriate way to move forward. So I'm going to ask for Carrie Tucker to come. Do we have a Carrie Tucker that wants to speak on the bill? Wow, that's good. How about Vanessa Hamler? And Miss Vanessa, I am reading other people's writing, so y'all be aware of this. Yes, ma'am. Thank you.
Hello, my name is Vanessa Hamler. I'm 42 years old, and I live in Cobb County, Georgia. Early on, I grew up a very healthy person, and up until 2013, I had 2012, I had absolutely no issues, no health issues. 2012, I was diagnosed with rheumatoid arthritis. It left me bedridden. Thanks to my biologics that my rheumatologist eventually put me on, I started back being able to perform a fairly decent life. Military family, 2 children, so we were very active. So it kind of gave me somewhat of a normal life. I see my rheumatologist probably more than I see a lot of my family members. I see them about 3 or 4 times a month on average. And it is important to me that if my rheumatologist writes a prescription for me and I take it to a pharmacist, it is important for me, for not only for the pharmacist to let me know that they're changing it, but also to let my rheumatologist know within a reasonable time that they're changing the medicine. Excuse me. The reason why it's so important to me is last year, one of my medicines that I was taking for rheumatoid arthritis caused me to develop a form of lupus. And if my rheumatologist didn't know that I was on a particular drug or I had a change, for example, he would have thought I was taking one, and I was in fact taking another. So that's very important for patients like me.
Thank you. So you support the bill?
I do.
Thank you so much. Ayana?
Thank you for your attention this afternoon. My name is Ayana Charleston. I represent the Arthritis Foundation. Vanessa Hamler is also here on behalf of the Arthritis Foundation. We are in full support of House Bill 195 as it's written. We certainly are encouraged by the introduction of biosimilar and interchangeable biological products to the market. And we thank you for your consideration of this bill, and we are particularly in support of the communication provision written in the bill, the 48-hour notice. As Vanessa mentioned, it's incredibly important for patients to be aware of the change, but more importantly, for the prescriber to be aware if a substitution has been made at the pharmacy. So unless there are any questions, I thank you for your support and your attention.
And are you with any association? Or
Arthritis Foundation.
Very good. Thank you so much.
Thank you.
I'm going to ask anybody that comes up to tell us who they are, where they're with, or who they're with, and to give us a brief yay or nay and why they support. Boyd Pettit. Boyd, you here? All right. Miss Glasser. Dorothy. All right. Alan Hayes.
My name's Alan Hayes, and I obviously picked the wrong day to represent health insurance companies and rise in opposition to the chairwoman's bill. But I represent AHIP, which is America's health insurance plans. We represent the health insurance industry, including the supplemental products, the Medicare, Medicaid products, the ERISA administrators, and the the commercial plans. Our members cover 200 million American lives. And I say oppose the bill. We don't really oppose the bill. We certainly encourage, more than almost probably anybody, the advent and the introduction of biosimilars and interchangeable biologics. Hopefully they will drive down the cost of some of these biological drugs, because they are probably the most expensive drugs. It's not unheard of that these cost $50,000 a month. They're for your very severe diseases, chronic diseases. So we encourage and support the chairwoman in her effort to bring these to market, because it's really, really important for most of the advocates in the room who are having a hard time paying for this. What our problems are with the bill is that the bill sets new requirements that don't already exist in the law for generic substitutes. Having said that, I would say that it's a complex issue, and you've had a whole hearing about how complex this issue is. But to reiterate a little bit. Biosimilar, biologics are not new. The federal government started regulating biologics in 1902 with the Biologic Control Act of 1902, which predates the FDA by 4 years. Biologics are not new. Biosimilars are new. This idea that you can make something like it and charge less for it is very new. And there is a cancer drug that may come on market this year that's a biosimilar. And the FDA has come up with a pathway for those biosimilars. The FDA is still talking about a pathway for the interchangeables. Now, the interchangeable, first you have to be a biologic. There are no biologics yet. But if there ever is a biologic, you have to be a biologic for a while before you can even apply to be a biologic, interchangeable biologic. So the bill, if you'll notice, only deals with the interchangeables, which is, will be a generic form. And so, to make it real simple, but I don't think it's off base, what we don't know is we don't know what an interchangeable is. We don't know what the FDA is going to say about it. We don't know what the requirements are going to be when the FDA finally does. And even if they do come up with requirements, there may never be one. But what you do know, according to this bill, is that there should be stricter rules than there is currently for a generic substitute. So that's our biggest concern. We think the generic rule, the way it's been working, is working very well. It certainly benefits patients. It certainly encourages the generics, which is
I want to ask you something, and just give me a little liberty of members,
absolutely,
a little leeway for members of the committee. When we do things like look at some other things in health, one of them is the medical cannabis. There's a part of me that says the reason why we're doing that is in anticipation of federal action, and Georgia's actually ahead of the curve in being proactive. Could that be the case here?
I don't think so, because what you're doing is you don't know what we know what cannabis is. We know how it interacts with people. It's been
and I was using that as an example.
Yeah.
So, I mean, I just consider it kind of proactive.
I can see how you would say that, and that's certainly I would say it's premature.
Okay.
And others may say, well, they're so far in the future that even if we mess this up, we could fix it later. And
okay.
They're both probably very valid.
Right. Thank you, Mr. Hayes.
Mr. Chairman, may
yes,
I respond to that?
Yes, ma'am.
Well, first of all, you can tell that you work for an insurance company and that you're not in the medical field, because interchangeables come from biosimilars, not biologics. And the FDA right now has, I think, 4 applications before it for biosimilars. And what they will do is they will look at the biosimilars, and then if they meet a higher standard and get the gold star, they will be called interchangeable. So, biosimilars. So the FDA has those before them now, looking at them, and there's a good possibility that we may have one of those on the market, or more than one, by the end of the year.
Correct. Yes, the biosimilar.
No, we could actually have interchangeables, because they look at they first look at it as a biosimilar,
right,
and then they put a higher standard to it, and it
yes,
meets that higher standard.
Absolutely.
So we could have interchangeables on the market by the end of the year. Also, I would question that you really know anything about cannabis and how it affects the body.
Okay. I was just using that as an example. Sometimes you're ahead of the curve, and sometimes you're premature, and sometimes you're proactive. I guess it's all what side your bread is buttered on.
I don't want to comment on my experience with cannabis.
I understand. Yeah.
And I have, Madam Chairman, I mean, I'll agree with your staff, the long version.
Thank you. Thank you so much for that. In the interest of time and anybody that may have the munchies, we're going to call Marcus Downs. Yeah, don't you like following that?
My good friend, Mr. Chair, Marcus Downs with the Medical Association of Georgia. I just want to go back over some of the things that Mr. Palmisano shared earlier. We're an organization representing 7,500 physicians, and that is really important when we talk about this bill, because I want to let you know that we've grappled with this issue for more than a year. A lot of our physicians who deal primarily with these interchangeable biologics, biosimilar prescription drugs, our rheumatologists and our oncologists. And I don't speak for either of those groups, but I speak for the ones who are very vocal with the Medical Association. And at our annual meeting, we brought this issue before our House of Delegates. It was really important. At our most recent board meeting, our board decided that one of the issues that was of major contention was the notification piece. What we realized at MAG is that many states are struggling just to get notification. And so we have settled on and are very appreciative of Madam Chair's efforts to allow for 48 hours notification in writing once the substitution has been made. We feel that that is a very reasonable, actually a more than reasonable concession on her part and on our part. Again, just want to salute Madam Chair for offering this legislation, and also want to thank the pharmaceutical industry for being forthright with us and their intentions on this bill.
Thank you so much. Eric with the American Cancer Society.
Oh, you took my thunder away a little bit.
You'll pronounce that last name here?
Bailey. I should have been a doctor.
Yeah, I know the word
Or
Bailey,
may-
and that's
or may-
not it.
or may-
That ain't Reinders.
No, thank you. Just wanted to commend Madam Chair for being proactive in bringing this bill to the legislature. We stand in support of House Bill 195. As the new products hopefully do come on the market, there are provisions in the legislation that are really good safety measure for cancer patients. So thank you.
Thank you. Stephanie Kozel.
Very good.
It's not Bailey.
Good afternoon.
Good
My name
afternoon.
is Stephanie Kozel, and I represent Express Scripts, which is a pharmacy benefits manager. Express Scripts is the nation's leading pharmacy benefits management company, providing prescription drug services to large and small employers, health insurers, labor unions, and government entities such as Georgia, the state of Georgia. And we support the bill as introduced by Chairman Cooper and appreciate being part of the conversation.
Thank you so much. Jay Morgan.
I'm Jay Morgan, and I represent the Generic Pharmaceutical Association here in Georgia, Mr. Chairman. Just so you know, the utilization of generic drugs in Georgia's Medicaid program alone has saved tens of millions of taxpayers' dollars. I want to thank Madam Chair and the All-Star co-sponsors for your leadership on an emerging issue in healthcare innovations. The Generic Pharmaceutical Association supports House Bill 195 because this compromise language reflects our core principles, insisting on the science-based FDA determination of interchangeability. There are currently 4 biosimilars before the FDA for approval, so the Cooper language you are considering today is very timely. It allows for automatic substitution at the pharmacy. It treats interchangeable biological products and their corresponding brand reference products the same. It relies on electronic records to fulfill the communication requirement, meaning in an increasing number of pharmacies, nothing else must be done once the product is dispensed. So in many instances, current pharmacy practice is maintained. The compromise language is a vast improvement over previous language that we strongly opposed, and which originally erected numerous barriers to the automatic substitution of interchangeable biologics. So again, we thank you for this bill today and commend it to the full committee. Mr. Chairman, thank you for allowing me to speak today.
Thank you, Mr. Morgan. Russell Allen.
Thank you, Mr. Chair. I'm Russell Allen with Georgia Bio. We are the state's biomedical industry association representing pharmaceutical, biologics, medical devices, and related health innovation companies and research enterprises across the state. Our ultimate objective is to see that these innovative products make it to our patients. And our members, including those manufacturers of both biologics and biosimilars, very much support House Bill 195. We believe that ultimately it does ensure safety for the patient and communication between patient, pharmacist, and physician. Thank you.
Thank you. All right, here we go. Rick. Ready? All right. No one answered any of that. You want any closing remarks, Madam Chair?
No.
No.
Other than I just appreciate the committee's consideration of this bill and hope you will give it a favorable pass.
Representative Hatchett.
At the appropriate time, I would like to make a motion, even though I'm not a member of the all-star cast of co-signers.
Yeah, and we cried uncontrollably over that absenteeism. But this is the appropriate time.
In that case, I'd like to make a motion that this bill do pass.
Motion do pass. Any discussion? All in favor, please signify by saying aye. Those opposed, tread lightly. Like sign. Thank y'all. Thank you, Madam Chair.
Thank you very much.